I saw Dr. Meera Madam's name live.
Okay.
Live now, ma'am.
Yeah.
Yes,
Yes.
she's
Good evening.
there walking.
Okay. Dr.
Good
Sendil
evening.
is also here. Thank you.
Yes.
Good
Hi,
evening,
Dr. Sendil.
esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, panel discussion on challenges in menopause. Do we treat enough? Organized by OGSSI, Midlife, and Public Awareness Committee. So it's my privilege to introduce the Secretary of OGSSI, Dr. Meena ma'am. Ma'am is the currently Secretary of OGSSI and also co-chair of Eurogyne Committee OGSSI and also member of Eurogyne Subcommittee FOGSI. Ma'am has done special training in urogynecology, microsurgery, endoscopy, and also the instructor of basic newborn care and other
Thank you.
programs.
Sariti will go ahead.
Yes, ma'am. I hand over the session to you and I welcome you, ma'am.
Yeah, thank you, Sahiti. Now we move on with the OGSI prayer. On behalf of OGSI, I would like to welcome all our dignitaries and the delegates. And we go ahead with the OGSI prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with the blessing to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. So now I would like to start the program with the Kuthuvilakku lighting. It's a pride privilege. On behalf of our president and treasurer, I would like to welcome our vice president, ma'am, Dr. M.G. Dhanalakshmi, madam, who is the professor, senior consultant, Department of Obstetrics and Gynecology, SRMC, Sri Ramchandra Medical College and Research Institute, Porur, and she is an excellent academician, great teacher, and I have been attending madam's PG revision course during my PG days. Over to you, Dana, ma'am, to take over the session.
Thanks for the kind words, Ra. And as I was chatting with Usha ma'am, today's webinar is designed and executed by Dr. Sumati Premanand. I'm extremely thankful to her. And I know like she will do it in style, Shashi Tharoor style, I mean. Okay, and her usually her presentations are catchy and they will appeal to the public as well because it's a public um, what do you call the public program as well. I know many of us, when it comes to menopausal health, even the doctors, leave alone the doctors other than the OG, even the OG doctors themselves, those are not in the mainline stream, do give very less importance to this topics. I'm sure Dr. Sumati would have has roped in, all experts from all walks of life to make this meaningful and wholesome. Over to, Sahiti, can we introduce the panel moderator and the panelists for the day? I welcome you all on behalf of Midlife Committee of OGSSI as well as Public Awareness Committee of OGSSI, represented by Dr. Sumati Premanand.
Shahiti, can you share the CVs?
Yes, ma'am.
Yeah, Dr. Sumati, she's the Medical Director, Darshan Fertility and Women's Medical Center, and she's the Joint Treasurer of OGSSI, and she's a coordinator for Public Awareness Committee, both at OGSSI as well as for OGSSI for this year. And she's a poet, traveler, and blogger, and you'll see her Parinamam today. multiple facets today. The next slide, please. Dr. Usha Sriram, renowned endocrinologist, graduate of Madras Medical College, head of the Department of Endocrinology, Diabetes and Metabolism at VHS here, and President, Indian Society for Bone and Mineral Research, founder of Divas. Madam, Yuvadi is missing, madam. Okay,
I
Dr.
know.
Uma.
I will add it. Yeah.
Yeah, please add, madam. Dr. Uma Ram, All India Chair for RCOG IRC. We are proud to have you in our national arena, an examiner, Part 3, MRCOG, Faculty of Maternal Medicine at Gynecology Academy, coordinator for perinatal and mental health, short course for obstetricians, contributed chapters and edited books, and she is the managing committee member for OGSSI for this year and next year. Dr. Meera Raghavan, multifaceted personality, Secretary for Chennai Menopause Society, Executive Committee member of OGSSI, Core Committee member of Urogynec Subcommittee of OGSSI, Fellow Representative of South Zone RCOG, and recipient of various gold medals in UG and PG. And I think I'm proud to be associated with her as a treasurer in CMS as well. Next, Rajshri, my co-chair in Midlife Committee of OGSSI, life member of OGSSI, IFS, IMS, and IMA. She was an advisory committee member for OGSSI and 2025. Sorry, she is member Endocrinology Committee of OGSSI and a member of Indian Society for Lifestyle Medicine. That is the reason why she's introduced into this particular webinar. Diplomat of the International Board of Lifestyle Medicine, consultant at Apollo Medical Center, T. Nagar, and our area of special interest being preventive men's health. And she is a contributor to the book Labor by Dr. Geeta Arjun. Dr. Rajpriya Ayyappan, managing member for Home Fertility Center, Perambur, and Srinivas Hospital, and Secretary Women's Wing, Perambur IMA, managing committee member of OGSSI for this year. No, for last year. Sexual Health Committee member, OGSSI, and she's MRCOG Part 3 examiner as well. Dr. Sendil Kumar, a new entrant into OGSSI, is an orthopedician from MMC and RDGH, Chennai, consultant orthopedic surgeon at Sendil Ortho Clinic and Pain Care Center at Chelayo, in the Mission Hospital, Tamara, gold medalist in D Ortho and MS Ortho examination, selected for PhD by ICMR, DHR for Young Medical Faculty Program between 24 to 29. All the best to you, doctor. And then we have Ramya Raju ma'am, counseling psychologist and child development specialist, visiting consultant at Darshan Fertility and Women's Medical Center, Chennai, former board member at Developing Resources to Educate All Mankind Incorporation, USA, former chief coordinator at Yuvadi Trust, Chennai, served as child development specialist and counseling psychologist for a non-governmental organization focused on children with mental health challenges, contributor to mindful achievement of goals for individuals and committees, LLC, USA. Are we done with the, yeah, we are done with the faculty for the panel discussion. Over to Sumati, taking over.
Thank you, ma'am. Thank you, ma'am, for the kind introduction. Today, we are joining hands with the Midlife Committee for presenting this panel discussion. Thank you, Dana, ma'am, for all the kindness and for encouraging me to launch this webinar today. So let me share my screen. Are you able to see my screen?
Yes. Familiar
Okay.
screen.
Okay. Thank you. So good evening, everybody, and welcome to the first public forum of the Thinnai Talkies. This is an initiative of the Public Awareness Committee of OGSSI, and I must thank Dr. Sampath Kumari and the OGSSI AC for allowing me to use this terminology, because at the end of the day, whatever we are talking in webinars and in the meetings, it ultimately needs to reach the public, and that's the awareness I would like to bring about from now on. The entire world is made to believe that menopause is a part of aging. Acceptance is a virtue women should quietly possess around menopause. This is ingrained into all our systems, from home to workplace to society. This webinar will question the validity of that thought, break it, and it will provide solutions instead of patronizing the woman who is facing a midlife crisis. We have with us a beautiful bouquet of panelists, and I personally love each and every one of you for your knowledge as well as the experience in the chosen specialty. So, while I was looking through how men and women were named according to our ages, this was surprising to me to see how 7 different வாழ்க்கை பருவ பெயர்கள் were named for men and women. If you see this, you will know that you come to the end of the list. They all have, both of them have, 7 names, starting from Balagan to Mudumagan to Bedai to Perilampen. Look at the 7th point in the man. The man after 72 years of age is stage 7. Okay. It is in big contrast to the stage 7 of the woman who is barely 32 to 40 years of age. I tried searching as to what to name. அவங்க எப்படி கூப்பிட்டாங்க மத்த வயசு 40 வயசுக்கு மேல இருக்கிற பெண்களை அவங்க எப்படி கூப்பிட்டாங்கன்னு பார்த்தா அந்த ஏஜே அங்க இல்ல. Did women die, or did women didn't or men didn't bother to put it down, is something which I am yet to be enlightened about. So if men lost 20% of their skeleton by 50, there'd be $1 billion task force overnight. Women are losing bones every day. It is just called aging. When men have just aging, we have menopause and aging. We are still subjected to no scans, no hormone replacement therapies, no supplements. There is no urgency. Just a Mickey Mouse, okay, ma, எல்லாம் சரியா போயிடும், உங்களுக்கு வயசாயிடுச்சு, உங்க calcium சாப்பிடுங்க, you'll be fine, and pray that you don't snap a hip. This is almost a medical neglect. We can't look at menopausal women the same way anymore. All of us have our own selves, our patients, families, friends who present with these syndromes, each one of them. So the menopausal syndromes are broadly categorized into vasomotor syndromes, genitourinary syndromes, and the musculoskeletal syndromes. We are all used to social conditioning. Indian women have an average age of menopause of 46 years. Her average life of expectancy, however, has gone up to 70 years, expected to reach 77. Menopause, however, is preceding a lot of problems, and non-communicable diseases occur a decade earlier and in Indian women. We have a disclaimer here. The names in all these case scenarios are fictitious, but I claim that the real life case scenarios are over here, and you will be able to relate these case scenarios with your own selves or with your own family members, friends, or patients you've come across. Mrs. Kamala is a 48-year-old spinster. She's a lawyer. She is seeking advice regarding perimenopausal health. She has regular cycles, no symptoms, no risk factors. I would like to know how you will investigate. So shall we take this question to Dr. Uma Ram if she is here?
Yeah, Sumati, I'm very clear. Yeah, can you hear me?
Yes, Uma.
Okay, so she's 48, she's single, she's a lawyer, and she has regular cycles, no risk factors. Basically, should we give her
I want you to
hormone
address the
therapy or
investigations
supplements?
and the clinical examination on her. That is your question. What investigations would you do on this lady, and what examination would you offer her? She's just coming to you for, doctor, I am 48 years old and, I have to go for an examination, they said.
Yeah, so I think,
would you treat this as a window of opportunity?
Basically, we are looking to see, how she is overall. From the face of it, she doesn't have any medical problems, but need to get some history on what her, how, whether there are any risk factors that she has. We don't know what her weight is. We don't know what her family history is. So there are a lot of gaps in the information that we need to fill. So if you can just go back to the previous slide, Sumati, information that we have is that she's generally fit and well. She's 48. She's still having her periods and she's come for a regular check. So before we write the test, I think we need to categorize looking at family history and looking at her own history, whether there are, has she always had regular cycles, anything else in the past, any hypertension, any diabetes that you say no risk factors. So assuming all of that is negative, family history we need to know. At this point, I don't think she needs any hormone therapy. But has she had a breast exam is the first thing that I would do in a clinical examination. She definitely needs it, and we teach her how to do a self-breast exam. We'll check if she's had a mammogram in the past. If not, would advise a mammogram. Check if she's when her last pap smear was, and if she hasn't had a pap smear, this is an opportunity to do a pap smear. If she's had a pap smear and it is negative, then it's maybe after 3 years it's enough to do one. But we would offer it to her even though she's single and she's 48. Right? Many
What
times
exactly
single.
would you look at in a metabolic profile of this particular person? What would be actually your,
We need to
what would you
check
look
her.
out for?
We need to look at what her sugars are like, what is her glycemic index, how her lipids are, and whether she's anemic. These are definitely three things that we do need to do. And her thyroid. I think these are the minimum things that we need to do, and also get some kind of a feel for her diet, what is her exercise pattern, and mental health. So these are things that we need to identify.
The investigations and the clinical examination part. Yes. Thank you, Dr. Uma. So we will move on to the what are the symptoms of perimenopause your patients consult with? Dr. Rajapriya?
Okay. See, in perimenopause age, as you just illustrated, that woman at 48 years of age, most of them would have concerns that their cycles are going in for a little bit of variation. Suddenly they'll miss their period for a couple of months and then it would come. So we need to enlighten them that menopause is a phase of absent periods for a year. Very rarely they will come out with their sexual problems. It's mostly a provoked question about vaginal dryness or about decreased sexual drive. Very rarely they come out with those kind of questions. Yes, of course, urinary problems is something they would come out with, that there's either some amount of urge incontinence they're experiencing, or they might have some leaks on certain household activities. There are, of course, mood changes, which we are finding it out. The husband might come along and talk about mood swings, sleep disturbances, and a lot of them complain that I'm gaining weight. I'm gaining more weight, which I'm not able to control, although I'm watching my diet and I am taking time to do exercise. A lot of them have this mastalgia as a problem, which may be mostly cyclical, but for some people it is acyclic, and you have to reassure them whether it is fibroadenosis or not. And probably the underlying diabetes can give them white discharge with candida infections, or it can give urinary tract infections. So that's something we have to look out at. And sleep, mood changes, and weight changes disturb them a lot. It's important to address their sexual health by asking questions when they would come out as, yes, doctor, I don't have much of interest in sex these days, probably because of the vaginal dryness and some amount of dyspareunia experience.
Okay, thank you, Rajapriya. I would like to ask now Dr. Usha Sriram about the specific subset of patients who would reach you in menopause and perimenopause. What is the, because now that the gynecologists have answered questions regarding what sort of patients they see and how they go across, I would like to know, as an endocrinologist, are there patients who reach out to you around menopause and perimenopause for specific complaints? And what are the top 3 complaints they meet you with? Ma'am, Dr. Usha Sriram.
Yeah. First, thank you, Sumiti, for this opportunity. And yes, some women do reach out to endocrinologists directly or refer to us by our OBGYN colleagues or others for specific reasons. And as Dr. Omaram very rightly pointed out, that these are times when there are major changes in the metabolic health of women, and also they may be having some major changes in weight and things like that, so they may be reaching out to us for that. First, if I may add, this patient that you presented, we
Yes,
wish more women were like that, who come to us when everything is fine, and actually in a proactive way coming and seeking help, because really that is the time I feel, if we are able to get women to come even earlier, she's 48, if they could
yeah,
come in their early 40s or late 30s and find out ways to get healthy when they step into the menopause, I think they will come out of the whole that 5-10 year period, healthier. So that's something we can tell our public, that this is something they should prepare for, just like preparing for a pregnancy with preconception care. They should
yeah,
prepare for a menopause by getting healthy ahead of time, not by taking anything, but by getting their weight down, their checking their metabolic profile. So coming back to your question, women come to me either because they are finding that they are gaining weight, or the weight is in an unusual distribution. It's more an upper body weight gain. So they may come for that, and then we talk to them about changes in the metabolic profile during menopause, and also check out their thyroid, and counsel them on how to stay healthy going forward if they don't have a endocrine issue causing the weight gain, which is 90 to 95% of women don't have any specific reason. It's just changes in the metabolic rate. The second reason they come is if they've had, let's say, a master checkup, and they find that suddenly their lipid profile has changed a lot. Their HDL has gone down, their LDL has gone up, maybe some changes in their triglycerides. So this is particularly important, because whatever, if we are going to choose to give someone menopausal hormone therapy, it may have an impact on that. So definitely they come to us for that. And interestingly, and unfortunately, these changes happen very quickly. Within 6 months of the menopausal change, or when menopause happens, their LDL goes up and their HDL goes down. So again, this is another reason they come to us. And then the third reason they may come to us is again for any problems with their thyroid. Occasionally, women come to us because they are noticing some changes, like increase in facial hair, or hair loss, and they want to find out if there is a hormonal reason for that. And those are
okay.
reasons, but usually not a 48-year-old. And I just want to tell you that this week I saw a woman who's 48 and who found that she got pregnant, and she had termination. So that's
Okay,
always something to keep in mind, that is still possible, and women
yeah,
should be counseled about protecting themselves till the menopause happens. So these are all the reasons. Of course, they usually don't come to me for osteoporosis at this time. They may come with vitamin D deficiency related symptoms like generalized aches, pains, or muscle cramps, but that is not specific for menopause or menopause transition. It's
got it,
mostly,
ma'am.
or lastly, one question they come for is, do
Yeah,
I need hormone therapy? And maybe that's
okay.
something we can talk later.
Okay. Yep. So thank you for the answer. Now we face Mrs. Reena, who is 51 years old. She is postmenopausal since 2 years, but she has been having insomnia for the past 8 months. So how should we proceed to help? How common are these sleep disorders in women? Do we just keep telling people that உங்களுக்கு வயசாயிடுச்சு அவ்வளவுதான் தூக்கம் வரும் அதுக்கு மேல தூக்கமெல்லாம் வந்து வராது அதனால என்ன நீங்க காலையில எழுந்து வீட்டு வேலை எல்லாம் பாருங்க சாமி கும்பிடுங்க so this is something which we can't tell people but this is what happens in most households and I would like Dr. Rajshri to take this question because she is going to tell us a bit about the lifestyle medicine, the 6 pillars, what she is, sort of telling people to practice. And I want her to talk about sleep medicine and what is a sleep disorder in these women and how she's going to take care of them. Dr. Rajshri?
Thank you, Sumati. More than any disorder, it will just be because of the hot flushes, the changes that are happening in the family during that point of time and within herself, mental as well as physically. All those may not allow her to go to sleep early and she may have a disturbed sleep also. So the recommendation is more than 7 hours, at least 7 hours per night on a regular basis. And sometimes they may be on shift duties, most of them, so where they will have to accommodate and see that they get the enough amount of sleep required because sleep is very important for immunity, memory building, brain and bone health, and also stress reduction can lead to improved sleep. And when there is not enough sleep, you have hormonal changes, the cortisol level goes up, the insulin goes up, and then these leads again to increase in weight gain and stress also. So basically, first of all, we would advise her regarding the sleep hygiene. Tell her that to have a particular time to go to bed and a particular time to wake up, and use the bed only for sleep, to go to the bedroom only there. Avoid viewing her mobile, and the main exposure is the light that is going to be responsible. So to avoid the blue lights and the dim the lights in the house and watching television at least 2 to 3 hours before that. And regarding the diet, that's another one that affects sleeps. And so to have a dinner quite early, again 2 to 3 hours before she goes to bed, and avoid caffeine during in the evenings, preferably before after 2 o'clock in the afternoon, because it's known to reduce adenosine, which is very important for sleep regulation. And yes, limit liquids in the evening, preferably because she may be able to want to go to toilet, especially perimenopausal, postmenopausal. She may want to use the restroom more frequently. That way, limited in the night. And for some people, exercise can alter the thermostat and can affect sleep. So it is better to do it earlier or better in the morning than to do it in the evening, but it varies from person to person. So we tell her regarding the hygiene, what she eats, the light exposure, and then keep a time and use medicine, sleep, the bedroom only for sleeping, avoid screens, all
Got
these
the
she
point.
can do.
Wanted to know whether, after following all of this,
Yes.
what would you prescribe to her if she needs a medication? Would you give her a benzodiazepine or would you give a melatonin?
Benzodiazepine is not going to help her much, but it depends on why if it is a shift or sleep, then yes, melatonin will definitely help her. 2 milligrams, 3 to 4 hours before the bedtime will help her to get into sleep.
Okay, thank you. Thank you, Rajshri. We are moving to the next scenario for Dr. Rajapriya, Miss Monica. Miss Monica. She is 43 years old, architect, living in Dubai. She is a smoker. She's just consulting you online first. She is leading a busy life. She has delayed cycles. She's thirsty, dry, sleepless, sweating at nights. She's going to be married in 6 months. However, she wants to conceive naturally. She has regular cycles right now. She wishes to preserve her youth. How would you help her? Dr. Rajapriya?
Now, these are kind of situations for career-oriented women who delay the natural onset of motherhood. Of course, we have to tell her upfront that at 43 years of age, with already certain symptoms of lowered estrogen in the form of night sweats and feeling dry and delayed cycles. So it is important for me to enlighten her. Yes, natural conception is possible. We just heard Dr. Usha Sriram say that someone at 48 turned pregnancy, provided their ovarian reserve is good. So ideally, she's going to be married. I will offer her premarital counseling assess her fertility potential, look at her ovarian reserve, what is her antral follicle count in a basal scan. I would do an anti-Mullerian hormone assay as well as a serum FSH basal, serum estradiol basal. If it looks good, some decent amount of antral follicle count, fair enough, I would encourage her that natural pregnancy is possible. But if I find out that her ovarian reserve is low and that's why she's having these newer symptoms of delayed cycles and certain sleep disturbances, then I would tell her it looks like she's en route to menopause and it may be difficult to conceive naturally. But if she insists her natural pregnancy chances, I would give her a shorter period, maybe 3 to 6 months to conceive post marriage. But offering a fertility preservation will not be a great idea because at that age, anyway, there are lowered follicles. And social egg freezing demands at the age of 43 at least 20 to 25 eggs to promise pregnancy, where that doesn't come in the picture at all. So giving a realistic picture and keeping her prepared by premarital counseling is the way to go forward.
Thank you, Rajapriya. So now Monica is 43. Okay. She's now married. She is married to a 39-year-old athlete husband. 3 days after her honeymoon, she has severe burning sensation in the vagina. She is unhappy because she is now avoiding sex when the husband demands it. But the vaginal dryness is not new to her, and there is an associated itching which she has been experiencing since 2 years. Dr. Meera Raghavan, I would like you to see this patient and do what you can.
Okay. Yes, she will need an examination if she is here. Or this, I don't think she's still online.
Yeah.
Is she still online?
Yeah.
Or...
Yeah.
Yes.
We are able to hear you. Talk.
No, I'm online. I'm asking if the patient still an online consultation, or I'm seeing her in person.
You're seeing her. You're seeing her.
Okay.
You're seeing her.
Okay. The vaginal dryness and the itching, it could be one of the two. It could be honeymoon cystitis, which she's having, or it could be precipitated by her dry vagina due to her perimenopausal symptoms, which already Dr. Rajya has addressed. The usual classic triad where they get vaginal itching and dryness. At the same time, they get urinary symptoms of frequency, the sensation to go to the washroom frequently, but able to pass only little amount, and sexual dysfunction. All three put together come under the umbrella of genitourinary syndrome. Unfortunately, majority of these patients start early with these symptoms of declining hormone status much earlier to the actual menopause and are often unnecessarily treated with antibiotics as nuclei, when actually it is the lack of estrogen which is responsible. A topical estrogen therapy itself will cure most of her symptoms and also enable her to engage in sexual activity, which is probably the need of the hour. So a proper examination looking at the thinning of the labial structures, the crystal acetates, the vaginal minors, and the features of activating which has to be seen and appropriately treated with the topical estrogen therapy.
Thank you, Dr. Meera. Let's now move on to Monica.
One more fact.
Yeah.
We should also emphasize one more fact. Many of our women obsess over perineal hygiene, thinking it is lack of hygiene which causes these symptoms and UTI. They have to be discouraged doing so.
Somehow the volume of your not able to hear as much.
Not very legible.
Yeah, fine.
Can you hear now?
Yeah,
Yes.
much better.
Much better.
They have to be discouraged not to have excess perineal hygiene because that itself can degrade the friendly bacteria and cause overt dryness. So a coconut oil application would be a better choice than repeated washing.
Little louder. ஒண்ணுமே கேட்கல.
Yeah. Somehow the clarity of voice வரல.
இப்பயும் கேட்கலையா?
இன்னும் க்ளோஸா வச்சு பேசுங்க மேடம்.
இப்ப கிட்ட வச்சு பேசுங்க.
They should be discouraged to have excessive perineal washing.
Okay. Now we are able to hear you. Yes.
Okay.
Thank you, Meera. So now Monica married, now has a kid. 3 years later, now she has moved to Chennai. Her menstrual cycle is 10 months ago. She is 46 years now. She is in good health, but she wants to start MHT. She wants to start on menopausal hormone therapy. She has reasons for asking that. She has a younger husband. She wants to prevent aging. And she has a friend in the US who is using an estrogen patch and claims that she is feeling younger. And she has no other risk factor. She has stopped smoking long time ago. I would want Dr. Uma Ram to take this question. Would you start her on an MHT right now because of these requests? She has no other risk factors. Clinical examination fine. Her weight is fine. There is no other family history or past history which would or her parameters, biochemical parameters, which will prevent you from starting an MHT. Her request is, can you start me on MHT because I have a young husband and I know I'm going to age very fast. I don't have any symptoms, but I think that MHT gives me a lot of benefits. So would you prescribe her or would you not? Dr.
I think,
Uma?
can you hear me? Yeah, thanks,
Yes,
Sumati.
Uma.
So this lady is 46. She's not had a period in 10 months. And she has kind of shown indication of being in a perimenopausal phase for a while now. I think
Yeah.
it's a good, at this point, we definitely have to take her wishes on board and,
Okay.
but I would like to document with some hormone tests what is happening to her ovarian, what is her, basically looking at her FSH to tell us where we are. Is this, because typically we need to say 1 year of no period before we can put the label of menopause.
Okay.
Even though we have all this, she's just, anyway, it's 10 months. So I would get a baseline and I would get a baseline ultrasound to check that her uterus and ovaries are normal. And if you say everything else is fine with her,
Yeah.
there is no contraindication. And for the people who are listening, contraindication will mean ensure she's not having diabetes, other risk factors. You
Yeah,
said
we are
she
going to
has
have a
stopped.
slide on that.
Yeah, so she stopped smoking.
Yeah.
I think we can offer her hormone therapy.
Okay.
But we need to counsel and check that, will she be happy to start getting her periods again? Because there are different types of hormone therapy that
That's
we
right.
can give. So we need to have a conversation. If we start you on hormone therapy, would you be happy to start having your periods again, or would you not want to have your period? That will decide what kind of hormone therapy we want to give, we can give. Definitely would do a breast examination and a mammogram to ensure that there's no problem before offering her hormone
MHT.
therapy.
Thank you. Thank you so much. Now Monica is 52 years old. However, she chickened out. She did not use MHT. Someone scared her off, quoting cancer risks. Now she is menopausal since 7 years, but she has gained weight of 8 kilos in 3 years. She has now started developing back pain and knee pain. She regrets having not started the MHT and curses her friends for discouraging her right now, at that point of time. Dr. Usha Sriram, what is your take on this patient right now? Would you encourage this patient to now start MHT? She is now menopausal since 7 years. Her biochemical parameters and everything else, there's no particular contraindication for starting MHT on this patient, clinically or biochemically or ultrasonologically. Now she says, I have wasted 7 years. I want to start MHT right now. Can you start?
So
Dr. Usha Sriram.
my quick answer is, so the when she was a few years earlier and when she came saying my husband is young or I want to stop aging or my friend in the US says I'm looking young, all those are not reasons to start at all. So because if we start,
The
we
volume is not,
no.
there's no clarity in the voice. Can you
Okay,
come closer and then talk, ma'am?
I'll hold it close to my, can you hear
Yes,
now?
ma'am. Now I am able to hear.
Okay. So I said when she came in earlier
Can't
and
hear.
said
Can't hear. Can't hear, ma'am. Can't hear.
okay.
Sorry. When she came earlier, how about now?
Yes, ma'am. Fine.
Okay. When she came earlier and said she wanted to start because her husband was young, or she did not want to age, or her friend in the US was taking it, right? Those are all reasons not to take. Because again, when those are all three, things that menopausal hormone therapy doesn't help, whether it's aging or whether it's other things. So there are specific indications for menopausal hormone therapy, because otherwise it will set her up for unrealistic expectations and failure. And now she has come with weight gain, and she has come with knee pain and all that. If that is the reason she wants to start, again, it won't help. So the reason why she wants the menopausal hormone therapy, it's not going to work. Currently, the reasons why we choose to offer menopausal hormone therapy are to women who are coming with moderate or moderately severe vasomotor symptoms, other either major sleep disturbances, even mood swings and cognition. Not so great, but you could try, because we also have non-pharmacologic alternatives. Okay.
She slowly brings out a serum lipid profile, which she has done yesterday to you, which says it is dyslipidemia, which was not there 3 years back, 2 years back.
True. And as I said earlier in my answer, dyslipidemia is expected. It may also be a function of this weight gain, right? So when we use menopausal hormone therapy, sometimes the triglycerides go up a lot. In fact, that's a negative effect of menopausal hormone therapy, like estrogen. So if it is something like lipid LDL level, it may come down. But again, we again have other alternatives for that, which are in the long term can be used. Menopausal hormone therapy can only be used in the short term. So I think what I would do for this patient is counsel her and say that these are all not the indications for menopausal hormone therapy, and send her to Rajshri for lifestyle modification.
Okay, wonderful, ma'am.
Sorry.
Now, Mrs. Divya, we are going faster because there are a lot of things to be covered. I'm so sorry, ma'am. So we are moving to the next scenario about Divya. She's a school teacher, 39 years old. She has got sleep disturbance, has hot flushes, night sweats. She is irritable and losing temper. She lives in a village, and in that village, she has had a total abdominal hysterectomy with bilateral salpingo oophorectomy in a younger age for a reason of fibroid uterus. She is reaching out since she is feeling overwhelmed. There is no other risk factor. How would you manage her? Is the question to Dr. Meera Raghavan. Dr. Meera?
Yeah, she's 39. She's had a few years.
No, voice.
We can't hear you.
Can't hear you.
Can you hear me now?
Can't hear you.
Little better, madam, now.
She's 39.
You can hold the mic closer, madam, little more.
She's 39. She's had a TAH-BSO. She's premature menopause. She's a definite candidate for MHT. For her, it is a definite indication. And she needs estrogen-only preparation. She can have a transdermal. But I'm wondering the feasibility of how she's going to take it, because she lives in a village. Nevertheless, it has to be emphasized for her betterment of general health as well.
Fine. Thank you. So what hormone therapy would you be offering to this lady? She's come to Chennai to consult with you.
She needs estrogen only therapy.
Estrogen only therapy.
Yes. I would
That is
advise
wonderful.
a gel, which is devoid of various other side effects. So gel or tablet.
Okay. So there are precautions when we are prescribing MHT, but we should not be misguided about this person who is a very young person, and we should know that this is a person who is going to be benefited for a very long period of her life when we start MHT. So what are the contraindications for MHT is something which I am simply going to play here and not ask any questions because we are running out of time. And why is estrogen preferred? All this is going to be available on the YouTube. It will be uploaded. So we are just running through this slide and moving towards the case scenarios. We now know that we have been using conjugated equine estrogen for a very long time, but now is the era of estradiol hemihydrate and estradiol valerate, which are better molecules, the synthetic ones. So we would also run through what are the effects of progesterone and CVS. Just want to ask one of you, probably Dr. Rajapriya Ayyappan, to tell why do you add a progesterone, because this is also a public forum. So there are non-doctors who are listening to this. For some of them, they may be getting a prescription for estrogen, and some of them may be getting a prescription for estrogen and progesterone. Why exactly are doctors adding progesterone to their estrogen prescriptions in such patients? Dr. Rajapriya?
Someone who is relatively on a younger age, say less than 50, if they have their uterus present, to overcome the unopposed effect of estrogen, where we are afraid about endometrial carcinoma, we add in progesterone to bring in a regular withdrawal bleed, which is kind of reassuring when they're young, they are happy about having cyclic periods. That would be at the point of the gynecologist view. I would like to hear further from Dr. Usha Sriram what she would think other than that from the endocrine point of view.
From Dr. Usha Sriram, I want to know certain answers regarding use of tibolone, SERM, androgen. Specific indications when you will not be using estrogen and progesterone or estrogen alone, but instead you would be using tibolone. In addition, you may use androgen. And what is the role of SERM? Which is the patient population you will be choosing for what? Dr. Usha?
So the ideal agent is, of course, estrogen. And as Dr. Rajpriya has outlined, if someone has an intact uterus, we cannot give just estrogen because of risk of endometrial hyperplasia and also future risk of endometrial cancer. So, and also a lot of irregular bleeding. So we absolutely usually have progesterone, either a continuous or a cyclical fashion. But what's important is when do we not use it? Of course, anytime there's an estrogen dependent cancer, some unexplained, vaginal bleeding, and liver disease, patients who have thromboembolic disorders. These are all pretty much absolute contraindications. Okay, there are a few relative contraindications as well. Estrogen dependent migraine, conditions like that, lupus erythematosus and all that. Now, when do we use tibolone? Tibolone is also actually it has estrogenic, progestogenic, and androgenic properties. It seems to work well for anybody with bone loss, and when you're considering it as a treatment for prevention of bone loss. But the thing is, it can help with sexual libido, especially. So if there is a postmenopausal woman whose primary concern is also decreased libido, tibolone is an option. When it comes to SERMs, because they are like designer estrogens, there are some, it's safer on the breast, but then it can increase risk of increased hot flashes. It's good for the bone, but it can cause, especially some uterine hyperplasia, endometrial, hyperplasia and all that. So we would consider SERMs in someone, let's say, with high risk of breast cancer, or one or already has a history of breast cancer. There are studies to show drugs like raloxifene are protective of the breast and of the bone. So if I'm using it for osteoporosis, then raloxifene is an option. Otherwise, we have moved away from all those drugs and just selectively use estrogen and progesterone and only for very specific indications.
Thank you, ma'am. Dr. Meera Raghavan, for that person who is that 39-year-old lady who had a surgical menopause, how long would you use menopausal hormone therapy on her? How long will you be medicating her? Dr. Meera? If Meera is not here, Dr. Uma?
Yeah, so she had premature menopause at 39, was it?
Yeah, 39. She had a hysterectomy and BSO.
Yeah. So generally, I would tell them that they need hormone therapy for a longer period of time, at a minimum 45, and then, decide about taking it forward till they're 48 or max 50.
Wonderful. Thank you. Thank you so much.
Yeah.
We are going to skip this because we'll come back to it if we find time. Mrs. Komalavelli is 56 years. She has had breast cancer treatment at 50 years. She is menopausal since 49 years of age. She has no other risk factor. She is working long hours in a rice mill. Heavy work is making her weak. She has had a fall in her outstretched hand. She had a Colles fracture 6 months ago following a trivial injury. And she wants to work to earn a living because she needs to earn for herself for till about 70 years of age. She wants to work. What are the recommendations? I call Dr. Sendil. This is what Sendil is what has been recommended by her friend. She is now having aches and pains. And I want to know, Sendil, what you want to do with this lady. What tests would you do? And then how would you take up this patient and how would you look after her? Dr. Sendil?
Thank you, Dr. Smriti ma'am, and thanks Oxy for inviting me to the webinar. It's indeed an eye-opener. This patient is an obvious case of a fragility fracture, where you can see there is a fracture of the trabecular bone. Loss of estrogen therapy typically causes fractures in the cancerous and trabecular bones, that is the hips and the spine and the wrist, as in this patient. So obviously there's a Colles fracture. The aim in this patient is to prevent further fractures. Okay. So what are the blood investigations start with? Since I work in the government, we don't straight away go for the DEXA scans and all. We first go with the blood test. Serum calcium is not the same as bone calcium. We have to make that clear, because we always say that if the calcium is high, I'm okay, I'm taking Shellcare HT for the last 10 years.
Yeah, I want you to tell about this calcium portion, because we see a lot of prescriptions about serum ionic calcium and serum calcium. How would you estimate whether this patient has got enough calcium in her or not?
This calcium is in the blood actually. So what we need to measure is in the bone. So to measure what is in the bone, we need to do a bone mineral density. Or for the blood parts, we can go for a alkaline phosphatase, serum alkaline phosphatase, which will give the osteoblast turnover. It's a marker of osteoblast turnover. It is not a gold standard test again. So what I do in my government and private practice, we go for a serum calcium, phosphorus, and alkaline phosphatase with vitamin D3. We see an epidemic of vitamin D3 deficiency across the spectrum of all ages, since we all confine ourselves to the indoors. So these are the blood parameters which first I start with. Then if there is an increased serum alkaline phosphatase, obviously it means there is a ongoing bone turnover or bone degeneration. So we can go for a DEXA scan. So the DEXA scan, how do we interpret the DEXA scan? There are two scores in the DEXA scan which you'll normally see: a T score and a Z score. The Z score is basically for premenopausal women, and T score is for the postmenopausal women. A score of more than 2.5 is osteoporosis, and 1.5 to 2.5 is osteopenia. So, and one more thing: this osteophytes, knee joint space narrowing. Most of the patients do not differentiate between osteoarthritis and osteoporosis. These two are not the same. They may be present in both the same patients, because an early menopause leading to weight gain, the patient can go in for osteoarthritis. At the same time, the patient can also have a porotic spine. So we need to deal both of this. Just by giving calcium, the arthritis is not going to go up. So how do I prescribe calcium? So what is the adequate amount of calcium needed to treat postmenopausal osteoporosis? By recommendations, it is say 1200 milligram. For a comparison, for a fracture patient, we give 1000 milligram of calcium every day, the treatment. And for a lactating woman, it is 1500 milligram. So if it is between these two, you can imagine how much of calcium is needed, number one. And what kind of calcium you prescribe. There are various calcium salts, carbonate, aspartate, citrate, and all. What we prescribe now as orthopedic surgeons is called calcium citrate, because of the compatibility portion. There is a lot of the calcium carbonate causes a lot of heartburn, so we always go for calcium citrate. That is number one. And is there any additional things which we can add here? There are various studies which show that isoflavones, actually, they are soybean extract, which have act on estrogen receptors. So they mimic estrogen effect, and these patients which with calcium with isoflavones are found to have increased bone mineral density over 5 years. This article is presented in the British Medical Journal itself. We have few products, only the cost is a constraint. This is one part. And vitamin D level. 800 units of vitamin D is needed for a postmenopausal osteoporotic woman with patient, as this patient is is obvious menopausal type 1 osteoporosis with fragility fracture. To prevent further degeneration here, I would start her on calcium. And if the patient is if the blood investigations are all positive, you can go for a DEXA scan. If the DEXA scan shows osteoporosis, as it said, it's osteopenia. So calcium with vitamin D and magnesium. The role of magnesium.
Yeah.
Okay.
What is the role of magnesium for this lady?
Calcium,
Do you prescribe magnesium?
Yes. Magnesium will enhance calcium absorption in the intestines, and with regard to collagen, creatine, I don't prescribe creatine supplements per se. Collagen is for arthritic knees. In earlier stage, that is grade 1 and grade 2 arthritic knees, we go for collagen supplementation, which prevent further degeneration. But once, if it is a mechanical effect, that is, if there is a varus or valgus knee, there is no use in going for a collagen supplementation. You need some amount of intervention. And this FRAX score, we have a FRAX score which for which we can evaluate these postmenopausal.
We can evaluate for evaluation. Yeah.
So, but
thank you so much for giving an elaborate answer over this question, which was much needed. So I am going to ask Dr. Rajshri to come up with supplements. There are so many things which are being told about supplements: fiber, isoflavine, collagen, creatine. What do you think is the right thing to do, Dr. Rajshri? Do they have to take it naturally, or should we have to buy supplements and eat?
Supplements can never replace eating a diverse and varied plant predominant food. Therefore, yes, we have to try to get them naturally, most of them. Fiber is only 25 grams per day, which is required, and it also depends on their gut health. If they have a constipation or something like that, they will need insoluble fiber for some time, which can be by fruits and vegetables you can increase, and temporarily you can give them. The soluble fiber is given for to raise lower the cholesterol and the insulin sensitivity. That's what it does, gets absorbed into the system. And that is available when you take whole grains, legumes, plenty of fruits and vegetables in your diet, nuts and seeds. That will increase the fiber content and you don't have to supplement. Regarding the isoflavine supplement, the supplements are no better than placebo. This is usually given for hot flushes. It's better to include the soy protein, which contains a lysine in the form of tofu, tempeh, or edamame beans and soy milk, and flax seeds also, which are good in lignans. So this will help with the hot flushes. We include it in the diet rather than supplements. Again, collagen, there's no point in supplementing it from outside because it makes up 1/3 of the body protein. So even when we supplement, it has to break down into amino acids and then it has to form. So you need a diet which is rich in legumes, green leafy vegetables, citrus fruits, which will help. And as far as the sunshine is concerned, sunscreen using, doing regular exercises is also important along with a healthy diet. Avoid smoking and alcohol and de-stressing. So looking into all these factors will help.
What do you think about exercises? Is this better or this better? Is this better or this better?
What do you mean?
Running on a treadmill or the household job?
Okay. Yes, we will not be able to maintain everything in the household job. Household job will give us the flexibility, and then it will also give us certain amount of strength when there is weight bearing, and then the balance also depending on what we are doing. But ideally, we will need the cardio or 150 to 300 minutes of moderate intensity. By moderate intensity, meaning that we should be able to converse when we are walking. That is required, 150 to 300 minutes. And strength training is very, very important in midlife that we are dealing about, because osteoporosis and sarcopenia are two things that starts even after the age of 30, we start losing the bone minerals. And so it is very, very important to do the muscle strengthening or resistance exercises using either the dumbbells or the resistant bands. Yes, or you can lift even water bottles with 2 liters, but resistant training twice a week, half an hour each, is very important. To prevent falls, you need the balance and the flexibility exercises also. Therefore, all of them are important.
Okay, thank you. Moving on to, you just have a couple of more case scenarios. Jennifer is a homemaker, 52 years, nulliparous, single, in a relationship. She has had myomectomy and endometriotic cystectomy at 41 years. She has now developed hot flushes. She has declining interest in sex, and sex is dry. Family history, she has had fragility fracture, and her ultrasound shows 3 centimeter fibroid. Is Meera Raghavan here to take the question about vasomotor symptoms? How are we going to manage her? Meera Raghavan? Dr. Umaram? Dr. Uma? Okay, now we are going to manage her depending upon her clinical examination, BMI, and in view of menopausal symptoms and age less than 60 years, MHT can still be offered to menopausal women or in menopausal transition. Regarding raloxifene, already it has been reiterated as to when to use and when not to use. We are moving across to Mrs. Parimalam, who is a 70-year-old widow. She is a retired Hindi teacher in Chennai. She has educated her children, but they don't live here anymore. They are abroad. She has been visiting doctors for the past 10 years, one doctor to another, complaining of extreme tiredness, fatigue, losing weight. She was not offered supplements enough. Her problems were ignored. Her GP investigated her and she has put her on Amlong 2.5 milligram OD for her mild hypertension. She is 40 kilos, only 5 feet. She's had a fall in May 2024 with a Colles fracture. She had a fall, a very trivial fall from the scooter in December 2024, just about 5 months later, and had a fracture of the right ankle and the left femur. X-ray is showing additional osteoporosis. She is now physically dependent on people. Dr. Sendil, do you think this could have been prevented?
Obviously.
Dr. Sendil.
Obviously. Yeah, obviously. Because since so many fractures and that too in the trabecular bone.
Yeah, come closer to the mic. Can't hear you.
Yeah. Am I clear now? Am I audible now?
Yes, yes.
Yeah.
So with these amount of fractures, obviously these are all fragility fractures affecting the extremities, and teriparatide could have been started earlier. See, there is a difference between pumping in calcium and getting the calcium to reach the bone. Teriparatide does the work, okay? And we have this denosumab. That is one more thing, which is a rank ligand that will be even more beneficial. So these are these patients when they have the first fracture itself, either the orthopedic surgeon or the OGSSI who's dealing with this patient should be should go together in treating these patients. So obviously,
how long would you keep her on these drugs? How long would you keep the lady on the drugs?
Yes. The teriparatide therapy is as a problem of overstimulation of the bone, which can indeed in turn lead on to bone demineralization. So 3 months is what is recommended, whereas denosumab is safe. So now we are moving on from teriparatide to denosumab injections when the patient does not have a fracture. When the patient obviously has a fracture, you have to get the fracture to unite. So teriparatide is an option, and to prevent further fractures, denosumab is the next thing.
Okay, thank you. This is about a 14-year-old housemaid traveling in a bus for her work, unable to hold urine for long, anxious if there is a traffic jam. She is wetting herself on laughing. It is very embarrassing for her. It is worsening day by day since a year. We have Mrs. Kamalam, who is 61 years, working for an NGO, menopausal since 7 years, extremely forgetful, forgets medicines, gets locked out, losing keys, misplaces objects. Unless she is listening, she is forgetting to buy her own grocery. Going to work itself is now challenging. Mind fog, dementia. These scenarios, are you able to understand that these are the people who we are meeting every day, but we don't look after. We have a gender divide. Are doctors not affected? Dr. Aarti is 52 years old and she is a gynecologist. She is running a medical center in Salem. She has delayed cycles, feels overwhelmed since 1 year. She is frequently having episodes of unrestrained anger, screaming bouts, both at home and at work. She has disturbed sleep, palpitation, anxiety regarding emotional instability, and she is preferring to sleep alone. Her daughters, who are studying in the college, want her to go for testing and for counseling. She refuses therapy. I want to ask Mrs. Ramya, what are the mental health symptoms in the perimenopausal women? Are they different from men? Mrs. Ramya Raju, are you here?
Yeah, she's muted. She's muted.
Okay, can you, okay, I'll call her. Can you take the question, Uma?
Yeah, I can talk while Ramya is able
Yeah.
to unmute herself. So actually, we see quite commonly mental health issues. Yeah, Ramya?
Yeah, I'm here. Sorry about it. I think I didn't see it. Thank you, Dr.
Yeah, sure.
So it's about the psychological symptoms, right?
Yes. Is there a big divide between what mental health symptoms affect men and women in this age group?
Yes, very much. See, actually, what happens here is you can see the slide highlights exactly how perimenopausal women experiences higher rate of depression, anxiety, and other mental health symptoms when you compare to the men of the same age. And what it is because it's just hormonal changes, and at the same time, they have life stressors also combined with it. So this is mainly a vulnerable time. And this is why this phase deserves, especially for women, more awareness and attention. Because depression affects 1 in 4 women, but whereas in men, it's fewer than 1 in 10.
Okay.
And it's just not
Why do
only
you think women are affected? What is happening inside them during this perimenopausal and menopausal time, which is making them be that? What is the imbalance here?
See, actually, during the stages, it's just not the hormonal shift. There is a hormonal shift, but nobody tells us or warns us about it. And these hormonal changes, it affects the brain. And especially the part that mood, memory, and sleep is affected. So let us at least talk about it, about the stuff we usually don't talk about. It's not physical. It's about mental health changes, and the emotional changes are real. So let me highlight just a few symptoms, like mood swing, psychological symptoms associated with women during the stages. The first is mood swing. It's a sudden emotional ups and downs. What happens here is, like, you can go from Bharati Kannamala, immediate Kanna Imekarthukula, you can move to Chandramukhi mode in just 130 seconds. And that is how the mood swing is for them. And second thing is anxiety. And she'll be staring at the ceiling. And even a simple message like, call me when free. You know how it sounds to her? It feels like some police FIR. She's scared, confused. And totally there is panic attacks. And what happens is, and the panic attacks, racing thoughts, and she has tight chestness. And all this starts from nowhere and it's real. Then again, even fatigue, simple things, even some days, even brushing her hair, she feels it's a chore. And brain fog, forgetfulness, I think you've spoken about it already, forgetfulness or difficulty in concentrating. You enter the room and you forget why you came for. You open the fridge and you forget why you opened the fridge. You forget your appointments. And the world is right, and the word is right here, but it doesn't come out. And again, loss of libido, intimacy issues is lots as they're seen here during this period. It's not that immediately what you think, it's not, the partner doesn't love you, but that's not the case. Actually, here what happens, your body is not responding and you don't know how to explain it to her, to your partner. And depression.
How are you going to take care of them?
Yes, by awareness. See, I will tell you about 3 A's. 3 A's is awareness, because most of the women are not aware of what is happening inside their body. They don't know because they have hot flashes, and what all they think is just, I'm feeling warm. And they dismiss it and deny it. That is not going to help them in any way if they're not aware of what is happening inside them. Or else they're going to be just like a frog in the pot of boiling water. And second is attention. You have to move to attention, because staying back with awareness, okay, I know, Raghuvar and monologue, Mari, everything I know, but you have to move to the next step of attention. It's like, the plant is dying and drying and it needs to be watered. But what we do is we just paint the leaves green. All that we do is taking care of the leaves, make it very shiny outside appearance. But that's not what your nervous system wants. It wants to be attended to. Your inner chaos, you're completely in inner chaos. And I'm suggesting all the possible things like you can go for yoga, you can go have some water, you can try Tai Chi, something you can do. Everything is possible. Everything is beneficial. But when your inner chaos is not attended to, your root cause of distress is not attended to, nothing is going to work. And third thing is adaptation. Unless and until you know the system I'm taking care of, otherwise adaptation doesn't work. Learning to say no more often. Women should learn this. You cannot be people pleaser all the time. You should learn to say no more often and move more often. No excuses about not exercising. I'm feeling tired. It's not possible. And eat differently. Because that, of course, these three things are not going to make you 18 when you're at 48 or 58. Definitely, this will not make you 18. But at least it will help you move through this transition period.
That is so good, Ramya. And
Thank you. Thank
I
you,
think we have overpassed the time with our good discussion going on. All I would like to say is advocate for yourselves, seek second opinions. Women in midlife cannot be ignored anymore for their aging menopausal symptoms. They are the ones who hold families and societies together, and let us hold them in good care. And to the women, don't ignore the signals in the body, tension, fatigue, or tight breath. They are not your weaknesses. They are wisdom. They are just waking you up. They are your nervous system quietly asking for gentleness. The more you listen, the more you will notice healing isn't about going hard on yourself, but it's about softening and looking at yourself. I thank our president with great vision, Dr. Sampath Kumari, and the OGSSI for the opportunity given. I thank Dr. Dhanlakshmi for always edging us towards bettering our programs. We are profoundly grateful for the esteemed panelists for having come during your hours to spend in discussion expressing your validated and evidence-based knowledge. We thank Shield Healthcare, Mr. Ganesh, who is a sales manager, Mr. Kirti, who is a regional sales manager, Mrs. Sahiti Priya, who is a senior executive webinar coordinator, for giving us an excellent webinar platform to take it to the other doctors and people. Thank you so much. I'm stopping to share my screen now. And okay.
Madam, we would like to take the questions now. Sumati Madam. So I request the
Are there
expert to say that
any
there are
questions?
questions.
Actually,
Yes.
we've overshot time,
Yes.
and that is what I was wondering.
So
The
we would
platform
finish
would
the questions,
close.
ma'am, because it is a recorded session. They would
Okay.
watch it on
Fine.
live
Dr.
also.
Dhanalakshmi, can you take the questions, please?
I've already answered.
Yeah, most of the questions were already
Are
answered.
answered.
In the chat
That is
box,
why,
yeah.
I mean, all this is already there. And
Yeah.
we will be available for answering. And this link is going to go on the YouTube. And if you wish your friends, family, or anybody whom you think needs to understand about their bodies or understand what's going on and what doctors actually discuss while prescribing this medication. No doctor is going to write you a prescription just when you go. They are thinking a lot. You must have listened to the cream of the society today, who has sat here, spent time about analyzing each and every case which has been put forward to them, think rightfully, and also educate themselves about what can be done, and also tell women about what can be done for yourselves. And it would be nice. Thank you all. Dr. Meena, your closing remarks and vote of thanks, please.
Yeah, thank you, Sumati ma'am, for the opportunity. So it was a wonderful session, well covered uh, cases, and all the practical cases were really dealt with. And so I really thank Sumati Premanand ma'am and all the esteemed panelists in the field of OB-GYN, endocrinology, urogynecology, orthopedics, counseling, psychologists, reproductive and lifestyle medicine, Dr. Usha ma'am, Uma ma'am, Meera madam, Rajshri madam, Rajapriya ma'am, Sendil sir, and Ramya Raju ma'am, and also Shield Connect. Dana ma'am has excellently moderated the session. Really like to thank our president, treasurer, and also Almighty for having given us the time and energy to go through this session very well. And all the questions have been answered in the chat. If there are any questions, we can take up later as well. Thank you, ma'am.
Thank you so much for
Thank
the
you, all of
opportunity.
you.
Thank you. Thank you.
Thank you. Thank you,
Thank you.
Dr. Usha. Thank you, Dr.
Thank
Uma.
you. Thank you.
Dr. Senthil. I mean, we wanted everybody. I mean, the only thing is we just ran out of time. Dr. Rajapriya, Dr. Meera Raghavan, Ramya. Thank you all for joining here. See you all then. Bye-bye.
Yeah, thanks for making women look
Sagiti,
at
you have
the,
taken
a
a
lot of
photo?
introspection has to be done. You want us to pose for a picture, ma'am? Dana, ma'am?
Yes. If Saiti has not already done it.
Sahiti, are you there? Or picture எடுத்துருங்க, madam.
Yes, ma'am, I'll take
My
some.
phone is not here. Yeah, Sahiti is there. Thank you.
Thank you so much. Have a nice weekend.
Thank you.
Bye.
Happy
Bye-bye.
Women's Day to
Have a nice
everyone.
week.